So Marie wants to know, what's wrong with me? How long is it going to take to get better? What can I do for it? And what can you do for it? All right, so the majority of the initial visit is spent finding out about the patient and their view of their condition. This may be like peeling an onion and take the majority of the time of your initial encounter. Be patient and don't worry about the time it takes. This is the most important part of the examination. The patient's perception is as important as their medical diagnosis or any imaging they may have had. However, imaging may have a huge effect on their perception of their condition. Their view of their health is the most important driver in their prognosis. The body heals, and as the patient's understanding of this improves, the fear surrounding their pain diminishes. Think about the visual illusion referenced earlier. Before education, the boxes looked very different in color, but following education and redirection, it was easier to recognize their likeness. Red flags is an area where all practitioners can and should be involved. If we see a patient that is in need of more urgent care, we should refer them on. Marie doesn't have any red flags that would prompt me to refer her to another provider, so I'll continue with her physical examination. I've already made mention of the subjective report and her examination findings. So these slides just have that on it. The physical examination is looking for functional abnormalities such as poor posture or hip or core weakness or faulty movement patterns that she's developed that may be contributing to her symptoms. These limitations are often easily corrected. I like to explain what I am testing as I go through the examination and why I am testing it. The more the patient feels comfortable with my skills, the more trust we will have in our relationship, and the more she will share with me that will direct my plan of care. I would describe my findings to Marie and move toward education about the nature of the problem and provide prognostication based on how long she has had the pain, the intensity of her pain, and yellow flags that she has. Some yellow flags that I found while interviewing her were that she feels like a victim. She's been passed around between an array of providers she feels don't listen to her and don't provide any lasting relief. She's having financial issues. There's catastrophization of her symptoms and fear that she will never get better, to name a few. Marie is here because she has pain in her neck, shoulders, hands, knees, and feet. Not just pain that's because of a recent accident, but chronic pain that she's had for more than 2 years. She was not referred with hopes that I am going to be able to change her anatomy. How can I best approach the treatment of her pain? First, create no fear. To avoid creating fear, I am not going to grab the model of the human skeleton or anatomical charts off the wall to explain Marie's pain to her. I am not going to pull up her radiographs or MRIs to reinforce an education she has already received. These can create fear that there is damage that for some unexplained reason is never going to heal. Instead, I am going to offer her something she has likely never learned before. An education that brings hope. I want to get Marie to reconceptualize her pain. I don't want her thinking about the bulging disc on an MRI that was taken months or even years ago. I don't want her thinking about the bone spurs she's been told she has or the developing arthritis or degenerative discs or any of that stuff because it creates more fear. I want her thinking about life, about activity, and about her goals. Sometimes patients don't want to talk about anything but what they know is causing their pain. When this happens, I simply ask them if they've found relief for their pain that is lasting? When they answer inevitably no, I seek to help them understand more deeply the pain experience. And this is some motivational interviewing. Why do you think you hurt? Do you wonder why your pain is not getting better? What do you think will help you the most? And would you like to know more about pain and how it can be controlled? Pain is complex. We shouldn't attempt to define it solely based on imaging or examination findings. It requires a deeper evaluation of all 5 of these areas listed in this diagram. So often, in the medical field, we only take the time to explain the nociceptive drivers and negate the contributions of the nervous system, comorbidity, cognitive, affective, and contextual drivers. No one individual has the answers in all of these areas, and developing a comprehensive diagnosis will likely require the involvement of multiple specialists in various specialties, working in tandem. When reviewing intake forms and taking a subjective history and performing my physical examination, I'm thinking about which category best fits the presentation of my patient. I'm considering what pain type fits the patient's symptoms the most, knowing that a combination of the types of pain is likely. While meeting with Marie, I see a strong correlation between what she is telling me and central sensitization, or nociplastic pain. How can I, as a physical therapist, have the greatest impact on a patient's chronic or persistent pain? Through helping patients reconceptualize their symptoms. I use metaphors, teaching that allows contemplation by the patient and an expansion of ideas. I help the patients reconceptualize their symptoms. I teach them about the nervous system and how it functions, showing them nerve diagrams and the processors or the receptors that are in those nerves, and how there's different types of receptors that will respond to different stimuli, seeking to explain to them why are they so sensitive when it's cold outside, or when there's a storm coming in, or when it gets too warm. Some patients become extra sensitive. So we talk about acute pain, about normal healing, helping them return to function as the pain diminishes. Would happen within weeks or months after pretty severe injuries with acute pain. And then I teach them about chronic pain, how there's abnormal pain that lasts greater than 3 months, and this is due to sensitization of the nervous system. Both peripheral nerves can become sensitized, as can the central nervous system. There's more than 400 nerves in the body, and if they were lined up end to end, there's more than 40 miles. And there's a lot going on in the nervous system all the time. So, further education, pain neuroscience. I talk about chronic pain and the sensitive alarm system as an analogy. I use the pain neuromatrix and how it's like a board meeting. All areas of the body are sharing information, and the brain, or the CEO of the company, has to piece it all together and make sense of it. We talk about nosy neighbors and the spreading of pain as the nervous system becomes more sensitive, and descriptions of how nerves function. The more traveled the road is, the easier it is for signals to go down that familiar path. Okay, so this is the fear avoidance model. I will teach Marie about this model in an effort to help her identify the cycle that she's been going through since the accident. She may have some questions, but often when I show this model, the patients agree that they're stuck on the left side of the model, and they're trying to find a way out of their pain. So her question of how long will it take? Well, it depends. Okay, so above is a case study in which a patient with chronic pain has had a functional MRI performed while watching Finding Nemo, then when asked to perform a painful movement. We can see the changes in activity based on blood supply to various areas of the brain. Look at the second row of images and how they light up. The third row represents the second row is when the patient was doing a painful movement after having rested, something that elicited her symptoms the most, which I think in this case was just forward flexion of the lumbar spine. The third row represents the brain's activity during the same movement following a 30-minute session of Pain Neuroscience Education. What a difference 30 minutes of education can make. We can have a huge effect on pain in a small amount of time. Just think about the difference this patient would experience if from the moment she walked into our clinic, she found herself in a healing environment with quotes like, "Hurt does not equal harm," "Movement is medicine," "Motion is lotion," and "Sore but safe" hung on the wall. How is this different than if Marie goes in and the first comment from her practitioner is, "Wow, look at this x-ray. You've got the spine of an 80-year-old. I have seen some patients with chronic pain for 4 visits or less who have experienced at least a 75% reduction in pain. And I've seen others who have continued to have pain, but their activity levels have increased significantly as they have stopped being afraid and gone back to doing many of the activities they were once avoiding. Those who have a change in perception experience a big change in their lives." I love this data. How encouraging it is as a physical therapist to see what a difference education can make. So what can Marie do for it? All right, wow. Look at all these ways that we can help Marie gain control of her pain. One of the first things we do as therapists is discover what helps ease symptoms. If my patient swears they just need an injection or a manipulation or a massage to help, I encourage these things while continuing to educate them about pain. In Pain Neuroscience Education, the purpose of it is to make the threat smaller. And as that perceived threat shrinks or diminishes in size, the pain that's produced also follows and decreases. Okay, so what can I, the provider, do for it? I want to promote self-care. Okay, I want to teach the patient coping strategies, help her get out and spend time with friends or nature, avoid situations that bring her down, find hobbies that are engaging and productive. It's good to be able to look around you and see all the things that you may have produced if you like doing crafts, or if you like chopping wood, or if you're, whatever activities that you enjoy doing, cleaning your house, those things that they might have been limited with for a long time. When they're able to start doing more and more, man, how that just encourages them and gives them a drive that they may not have had for years because their pain's been so limiting. So some of the ways, help them understand motion is lotion. It's okay if I get some soreness in my muscles because I'm using them and I expect that. And they've been deconditioned, or they haven't been used like they should be for a while. Remind them that movement is medicine. Hurt doesn't equal harm. Just because there's discomfort in the back does not mean that you're causing injury. And reminding yourself, I'm okay, my alarm is just sensitive for now. And that for now is really important with this because it gives that sensitive nervous system an escape. Okay, it says, okay, it's going to get better. And that hope that drives that is crucial.